to speak at this type of summit. I've given a lot of talks at a lot of different meetings, but this is just amazing. You know, I've given talks to thousands of people, but I think I'm the most passionate about this one. And I honestly didn't think that this would ever come to fruition. I have to thank Dr. Park actually for really getting people motivated, beginning a couple. Dr. Park, stand up. Dr. Park is an oncologist, originally from Korea, and has practiced here in the U.S. as well, and has a true passion for for gastric cancer or stomach cancer. And you know what Linda said, it truly takes a village. And to me, this was kind of one of these insurmountable topics. I go to Korea pretty frequently to give talks, and you know, a lot of their talks are on gastric cancer because it's so prevalent. And I'm here, you know, as a gastroenterologist here in the U.S. I have a large Korean population that I treat, but I can't get them screened because it's not part of accepted guidelines in the United States, and I found that completely appalling. And so, you know, when this all started to gain momentum with this, especially with this Pylori grant, I mean, I told them, I'm definitely in. I mean, I think this is one of the best things that has happened in the Pacific Northwest. I think that we're lucky to be here because of the Fred Hutch of cornerstone of the Korean population that we have here. And what actually pushed me to be more aggressive in this field was that for the past 10 years, I actually was at the University of Washington Medical Center, and it's you know, it's just a large referral medical center. But last year, I was asked to move over to Harborview Medical Center to be the chief of GI there. And if you don't know about Harborview, a lot of people think Harborview is just a trauma hospital and you just go there if you get in a car accident or something bad happens. But in reality, it's actually a safety net hospital as well. And so that's where most of our immigrant population go for health care. It's the safety net hospital. And so if you don't have insurance, that's where you go. And so when I moved over there, all of a sudden I had a huge bolus of Asian patients, and started to just see a lot of precancerous changes. And so it just kind of all happened simultaneously, and I'm excited. I do believe that this is just the beginning, and you know, I'm not going to quit until we have national guidelines that clearly delineate screening recommendations for high-risk populations. And so my talk here will kind of give you a background of what gastric cancer is. I mean, fortunately, I think I'm talking to a group of an audience who is relatively knowledgeable that gastric cancer is a problem. But what's amazing is my colleagues in GI don't think that gastric cancer is a problem. You know, my colleagues in GI, I was on a conference call recently, and a very well-known person, he just says, oh, you know, we can't do this. This is just as ridiculous as screening for gastric cancer. And I just, I almost blew a gasket. And it's just like, but that is how gastroenterologists think right now in the U.S. because it is Caucasian-centric. You know, it is based on what the incidence is in the general Caucasian population. And fortunately, the NIH and other health organizations are identifying the need to look at ethnic variations in healthcare and disparities. And this is probably the most blatant and most obvious disparity that exists today in all of medicine. And so I'm sure that logic will prevail and we will eventually be able to get there, but it's going to be a long path. So let's go on to the first slide. We'll talk, go ahead. So the ASG, I'm part of the American Society for Gastrointestinal Endoscopy. And we do actually have guidelines. I was on the guideline committee, and these are obscure guidelines, but it says we suggest screening endoscopy, EGDIS endoscopy, for gastric cancer in new U.S. immigrants from high-risk regions around the world, such as Korea, Japan, China, Russia, and South America, especially if there's a family history of gastric cancer in a first-degree relative. But they deem it low-quality evidence, and so if you want to screen, you can have this discussion, you know, with your patient. If you come from any of those that basically are red or orange, but that's actually a large population. Stomach cancer is the second leading cause of cancer death worldwide. So it's a big worldwide problem, but for some reason in the US, the incidence is low, and so we have a tendency to ignore it. We don't really put much effort into it. But the US is a very unique country, right? We are an immigrant country. There are very few truly native people to America. I mean, they come from all over, and so it's going to be an important task to educate people about ethnic variation and to understand differences in disease from other parts of the world. Next slide. So I'm a Korean man, or second generation Korean, so this is also why it's kind of important to me. And you know, my grandfather died of stomach cancer, and so Korean men, sorry, I apologize, I'm just not prepared for this, but Korean men, they're 7 to 8 times higher risk of developing gastric cancer than the Caucasian, you know, their Caucasian counterparts. Vietnamese men and other Asian American men are 3 to 4 times greater, have a greater risk of developing gastric cancer. And the sad thing is there's something that we can do about this, and we're not doing it. So if you see on this graph, I mean, Koreans has the greatest disparity. We have Filipinos down at the lowest, which is 7.2, but that's still twice the level of the Caucasian population. To put this into perspective, you know, we have a national guideline here for colon cancer screening, right? Katie Kirk really made a dent in us doing colon cancer screening, you know, because her husband died. The risk, or the incidence of colon cancer, and this is per 100,000 people, is exactly the same as that for Korean men and their risk of gastric cancer. So it makes no sense whatsoever to not screen this population as well as the pretty much everyone on this screen, and because we do have good screening techniques. Next slide. American women, Asian women face the same disparity, high incidence. Fortunately, females are relatively protected. They have basically a 50% less chance in their ethnic than their male counterparts by ethnicity, but they're still at higher risk of developing gastric cancer. Next slide. And so here's kind of the slide across, and this is where it kind of gets mixed up, you know, because we have a tendency to group people in race, and so it doesn't. It kind of blunts the disparity that exists, particularly for Korean and Japanese men. Because if you look, we're often put into the Asian American group, where they say, well, it's only 7.1 per 100,000 compared to Caucasian Americans, which is 8.7. So it's barely, you know, twice the risk. But again, if you break it down by ethnicity, you know, Koreans, again, we're at 54 per 100,000, and so that's a huge disparity, and so that's what we need to start addressing. I think that, you know, sometimes we're too cautious on being politically correct and not wanting to separate out ethnicity, but in health, there are clear genetic variations, and either by cultural regions, you know, what we eat, or more likely, there's also a strong genetic component to it as well. There are groups that are at higher risks, and we can do something about that to decrease that, because this is a completely preventable and treatable cancer if caught at the right time. Next slide, please. So all minorities face greater risk across the board, and so this is a minority disparity issue, and the question it always gets to, you know, in terms of screening test, to talk a little bit technically, it's a cost effectiveness thing, and so if you have an effective test that's relatively cheap, you can screen more people who are at higher risk. But right now, I can be fairly confident that it'll be unlikely that we ever screen the entire population for gastric cancer because the incidence is so low. But the key is to identify the appropriate groups to screen so that we can make interventions, we can catch disease early, or even prevent prevent cancers from even happening, or detect them at early stage. Next slide. So, is screening effective? I mean, I wouldn't be here if you know, screening were useless, but we have very effective screening tests, and we can see just from looking at the data out of Japan and Korea that screening improves survival. In the US, if you're diagnosed with stomach cancer, basically in 5 years, your likelihood of being alive is about 25%, so 1 in 4. So you have a 1 in 4 chance of surviving 5 years. Whereas if you're diagnosed either in Japan or Korea, your likelihood of being alive in 5 years in Japan is about 62%. In Korea, has interesting data because in 2006, they instituted a national policy of the government paying for screening. So it became a national policy. And so what you have comparative data pre-screening, and although Koreans were doing screening, it just wasn't covered by the government. But with that institute of policy changed by the government saying that screening will be covered and is mandated for Korean patients, you had an increase in 5-year survival up to 67%. So you took the highest incidence, the highest occurring cancer in that country, and you dramatically improved survival by instituting the screening program. Next slide. So one could argue, well, you know, you have a higher 5-year survival rate because you're detecting disease at an earlier stage, and so it just looks like they're surviving longer. But this one breaks it down by stage, and in Korea, so if, looking at this data, if I had early gastric cancer, I'm going to Korea. Because for early gastric cancer, 51% of patients identified were diagnosed at early stage, and their 5-year survival is 92.4%. So very high, you know, so it's no longer a death sentence at all. Whereas in the US, even if you're diagnosed at early stage, for some reason, we're not very good at treating. And there's a 62% 5-year survival, which, you know, doesn't make sense to me. And so it tells us that we're also doing something wrong in terms of therapy. These patients in general are getting their stomachs cut out in the US, which is different than what they do in Korea, and I'll kind of show you the difference. So in the US, if you're diagnosed with gastric cancer, the standard of care right now is to take out your entire stomach, which is a pretty huge surgery, and so that might have survival implications. Whereas in Korea and Japan, and something that I've just started to do, there's a local therapy that I'll show you a video of, where you no longer have to remove the stomach. You can just take out. If you can diagnose it at an early stage, you can just do a local resection endoscopically, outpatient procedure, or maybe one day overnight. So that's another reason that I'm making this push, and that there will be a push by gastroenterologists, because it's a new procedure that we're doing. It's actually really cool. A lot of gastroenterologists want to start doing it, but in order to start doing it, we've got to diagnose early gastric cancer. And so I think, again, there's a steamroll effect. Everything's kind of coming together at the right time. But if you look at distance, so the distance is an advanced stage, it's just bad, period, right? So with 5.5% survival, 5-year survival in Korea, 3.7 in the US, pretty similar. So the key is not to diagnose at an earlier stage to improve survival. And this is a relatively asymptomatic disease, and the only way we can diagnose at an early stage is to do some form of screening. Next slide, please. So this is just a simple endoscopic picture. This is the end of your stomach. We can pretty much diagnose what's called intestinal metaplasia or gastric intestinal metaplasia. This is the precursor to cancer endoscopically. Not all patients who develop these changes go on to develop cancer, but patients who develop this change, it's gastric intestinal metaplasia, patients who develop this change have basically a 7 to 8 times greater risk of developing gastric cancer. So these are the ones that we need to follow. Next slide. So we'll talk about screening strategies. So we can also do what's called magnification endoscopy, where we can go up there and really look at the mucosa and diagnose this gastric intestinal metaplasia. And we can actually we're getting pretty good to the point where we can actually diagnose early cancers just by looking at it. So next slide. So what is gastric intestinal metaplasia? So it's a precancerous lesion in the stomach, and this is the key to detect and treat early gastric cancers. And so patients who, again, develop this, those are the ones that we need to keep an eye on. Again, not all of them will go on to get gastric cancer, but their risk is so high that those are the ones that we need to keep an eye on. So again, 6 to 8 times higher risk of getting gastric cancer, and if they have these other changes of inflammation, again, the risk is even higher. So the other important thing, people talk about H. pylori, and I'm sure that all of you have heard about this infection, Helicobacter. Yeah, how many people are familiar with H. pylori, Helicobacter pylori? Yeah, I think as a country we've done a very good job in educating about Helicobacter pylori. The U.S., our baseline rate is about 20% of people, the population, have H. pylori. Well, Korea and other Asian countries, their incidence of H. pylori is about 80%. And so most primary care physicians know to actually test their patients who are Asian or come from high-risk areas for H. pylori. There's a simple blood test that you can do, and then they will treat that. But the problem is a lot of times they think, okay, I've identified it, I've treated it, I'm done. They're no longer at risk. Well, that's not true. The important thing is once you've developed gastric intestinal metaplasia, it doesn't matter if you have H. pylori or not. In fact, you had H. pylori in order to get gastric intestinal metaplasia. It's one of the things that drives that. The people who are actually at highest risk of developing gastric cancer are those who no longer have H. pylori, but have gastric intestinal metaplasia, because they have advanced gastritis that basically the H. pylori infection has burnt out. And those are the ones who are at higher risk. So you can't just screen for H. pylori and tell someone, oh, you're H. pylori negative, or we've treated your H. pylori, you're no longer at risk for gastric cancer. You really have to assess their stomach and see whether or not they have these advanced changes to tell whether or not they have, if they really have risk of developing gastric cancer. So next. And this is just a slide that demonstrates that. And so it's hard to see, but there's two lines on the bottom. That's group A and group B. And group A is basically patients without H. pylori infection and without this gastritis or without this intestinal metaplasia. Group B is patients with H. pylori infection who've been treated, but also don't have the atrophic gastritis, intestinal metaplasia. But what's really interesting is now group C, which is kind of this middle one that's starting to go up, that one is patients who have H. pylori, had it treated, but have intestinal metaplasia. So their risk is higher, and their risk is basically about 6 times that from the baseline. But if you have this intestinal metaplasia and atrophic gastritis and you don't have evidence of H. pylori, you're at actually highest risk. Right? And so if you just screen for H. pylori and you say, well, that, you don't have H. pylori, and you don't look for this intestinal metaplasia, atrophic gastritis, you're actually missing the highest risk group for gastric cancer. And so that's why you need something in addition to H. pylori, and that H. pylori is not a sufficient screening test for gastric cancer. Next slide. If you do have these changes, there are some recommended screening strategies, again, not in the US, but elsewhere. If you have these changes, then if you're at higher risk, if you have one of the following, if you have basically extensive intestinal metaplasia in your stomach, if you have this one pathologic stage called incomplete intestinal metaplasia, if you have a first-degree relative with gastric cancer, or if you're a smoker, you are at higher risk. You're at 2 to 3 times higher risk than your counterparts who don't have those risk factors. So we recommend that you have yearly endoscopy for those patients. If you just have intestinal metaplasia without those other risk factors, then you probably can have it every 2 to 3 years. Next slide. So patients with gastric metaplasia and dysplasia who are at increased risk for gastric cancer due to ethnic background or family history may benefit from surveillance. I do want to go back and say one thing. If you are Caucasian, though, and you have intestinal metaplasia, your risk is actually still incredibly low. And so the national guidelines from the ASG and the AGA, they actually say even if you have intestinal metaplasia, you don't need to get screened. Most patients don't like that recommendation, and I still have a discussion with them. They're still at higher risk. They're still at probably twice the risk of the baseline population, but again, it's twice the risk of a relatively low incidence. But when you talk to them, in general, they want to continue to get screened, and I usually continue to screen them. So when we do endoscopy, we need to do some mapping biopsies, so we take biopsies from all over the place. And then patients who have what's called high-grade dysplasia, basically it's the one step right before cancer, are at significant risk of going on to cancer. So then we should do some type of therapy to remove that. And right now, actually, if you were to be diagnosed at most places here in the U.S. and you had high-grade dysplasia, they would recommend taking your entire stomach out. And so that's pretty drastic. So what we want to do is kind of educate gastroenterologists, surgeons on what the appropriate therapy is. Next slide. These are just some slides of what gastric cancer looks like. There, you see this is a scope, and it's coming in and it's looking back on itself. And so you see that little raised bump. They're very subtle lesions. They're not, you actually need to be trained to look for most of these lesions. And US endoscopists are not trained at this time. And so you have to, in general, I don't recommend Korean patients just going to their local gastroenterologist. You want to go to a gastroenterologist who has an interest in diagnosing gastric cancer or early precancerous lesions. Next slide. Because some of them can be very subtle. This is just kind of a lumpy, bumpy appearance, but this is also gastric cancer. Next slide. And then this one's relatively clear. This is an ulcer, but this can just be mistaken for an ulcer. And this is exactly what an ulcer looks like. And if you're not thinking that this potentially could be cancer, you could just say, oh, you have an ulcer, take this antacid medication, and you'll be fine. Next slide. So here's the video. Go ahead and play this video. This is what endoscopy looks like. Actually, is there a way to get the lights down? It's kind of hard to see. But there's a lesion kind of right on the right side. Yeah, so you can see a little bit better there. We use special imaging techniques to kind of accentuate that. And these are subtle lesions. These aren't like big, enormous tumors. So this one just looks like a subtle ulcer. And we can kind of change imaging techniques to really look at this. So then what I can do now, I did this procedure, we can then go around and we can mark the lesion with cautery. So we go around and we just use some cautery. And that whole area is probably about 3 centimeters in width. And then we'll go in and inject underneath the mucosa. So the gastric wall has many layers, fortunately, and the early cancers happen just on the superficial layer. So the idea is just to remove that superficial layer. So this is where, a lesion like this, to take your whole stomach out seems pretty drastic, and it just is life-altering. So what we do here is we just inject some fluid underneath one of the layers to lift it up, and then I use this cautery knife, similar to what surgeons, this is more like microscopic surgery, so through the endoscope, I can basically cut the margins of this tumor out, and so this is where I'm kind of cutting the perimeter, and then I will then, underneath the tumor, I'll dissect out the tumor. So this is a scary procedure. I mean, it's, because the wall of the stomach is just a few millimeters thick, and if you just go too deep, you can put a hole in the stomach, and that, then the patient would require surgery, go to the intensive care unit, potentially can be life-threatening. And so it's a nerve-wracking procedure, but it's certainly, it's shorter than surgery. The patients usually can go home either that day or the next day. The only real risk is kind of risk of bleeding, because I basically created an ulcer with this process. But it's, once you take it out, it's very rewarding, because you've cured this patient of cancer. You're not done. This patient's at risk of developing further cancer in the future, and so you have to keep doing endoscopy on him to make sure that he doesn't develop further cancers. But this has dramatically changed therapy of gastric cancer, and this is also another compelling reason as to why we should do screening for gastric cancer. Because in the past you do screening, but then you think, oh, we found something early, what do we do about it? Do we take your stomach out now, or do we watch it? And the options for therapy were limited, but now we have wonderful therapeutic options to present to the patient if we diagnose an early gastric cancer, and it is significantly life-changing. Next slide. So kind of take-home points. Gastric cancer is a worldwide problem, and we need to be cognizant of that. Gastroenterologists in particular, I think we're very ignorant. So one big part of this process that we've talked about is to educate primary care physicians and gastroenterologists. Korean Americans in particular are at highest risk in the entire world. So again, my passion for this. But it's high in almost all minorities. Screening programs in South Korea and Japan clearly have improved survival. There's no doubt about that. And so we need to start doing that for our patients who are here in the US. And we've developed new methods of therapy that are effective in treating early gastric cancer. They're no longer do they need to take the entire stomach out. And so I think that the future is very bright for moving forward. And this is, incredibly ripe, and I'm glad that we have everybody here together in this room to talk about this, to move this forward. I certainly couldn't do it. I've known about this problem for a long time, and I feel guilty that I haven't been able to move the needle. But it really is the community that moves the needle on something like this. I mean, it's the patients, the community who has to ask for this. And unfortunately, we're talking, some of the immigrant communities are underrepresented. They can't speak for themselves. They don't have advocates. And so, I mean, we as a society really need to, push healthcare, push the legislature, and, really make changes. And, changes here that we make here at a local level will have national and potentially global implications. And so this really is an amazing summit. And I'm so happy that we had such an amazing attendance, that there's so many people that are interested in this topic. And I when I heard that this was initially thought to be a one and done summit, I was like, no way, we're just getting started. And I hope this audience doubles next year and continues to double. And I think that this will be, I think we're just starting the engine and getting moving. And I think a lot of people are going to jump on. And you're going to get a lot of support in the future. So I applaud everyone who's here, who has an interest, and I hope that we can all work together to push this agenda. So thank you.